Fine.
Thank you. Well, good morning, everyone. I always love being first. I hate being after lunch, so hopefully I'll keep you awake this morning. That's my goal. But thank you so much for inviting us to come and meet with you. You know, we do a lot with our partners here in Tennessee and the folks at TBI and other agencies, so we're glad to be here. And on behalf of my boss, Joe Ranazizi, and my administrator, Michelle Lenhart, thank you so much for inviting us. This morning, what we wanted to talk about is DEA's response to the prescription drug abuse crisis. It's a pretty robust response. I'm going to be moving through a lot of stuff quick. This is all part of my strategy to keep you all awake. So I'm going to move around a little bit. I've been a policeman for 27 years, so hiding behind a podium scares me than going through a crack house door. I like to move around. So if you're going to throw something, you got to be quick. And for those of you that are sitting near Tommy Farmer, he's seen this 12 times. If he starts heckling me, I need some help. I'll just point him out to you, Farmer. So what I'll do today is give you sort of a national overview of prescription drug abuse, sort of perspective from DEA, what we're seeing, sort of scope of the problem. Talk to you a little bit about the checks and balances of the Controlled Substances Act. I'm going to breeze through this real quickly, but there's a reason I'm doing this. I want you to understand how major trafficking organizations that are involved in the prescription drug abuse distribution process throughout the United States, and players within the legitimate controlled substance movement system in the U.S. are avoiding the law, or trying to avoid the law to distribute drugs. Then I'm going to talk to you about where people are getting their drugs. Places like the medicine cabinet, places like doctor shopping, the sort of doctor shopping phenomenon we see. And then most importantly, I really want to focus this morning a little bit on the evolution of pill mills. You know, it used to be a Florida problem. It's not a Florida problem anymore, and I'll talk a little bit about what we see on a national level. And then, of course, what we're doing in 3 different areas in particular: disposal, enforcement, and education. I think Regina LaBelle was here from the Office of National Drug Control Policy. She probably talked about the national strategy and the 4 pillars. We're really involved in 3 of those 4. So let's talk about the prescription drug problem. A lot of times, there's an alternate title for this. We call it Responding to America's Prescription Drug Abuse Crisis When 2 Addictions Collide. First question this morning: what do you think the 2 addictions are? Anybody? I'm going to let you off the hook a little bit. It's an insatiable appetite for opiates, prescription drugs, but in particular opiates, and greed. There's a ton of money involved here. A lot of people are making a lot of money pushing drugs out that are killing lots of Americans. And we love, absolutely love, our drugs.
Ever had a slight headache or woken up with a stiff neck? Do you get cold when it's chilly? Hungry if you don't eat? I know I sure do. Until recently, I thought I was perfectly healthy. That's when my doctor told me about Pretenditrin. Pretenditrin alleviates the symptoms of MDD, or mild discomfort disorder. It changed my life, and it can change yours too. With Pretenditrin, I'm confident that whatever's not wrong with me is being treated. That's only half the story. Research has shown that good health is genetic, and I worried that what was not wrong with me could also be not wrong with my kids. So I'm relieved that now there's Pretenditrin Jr. And coming soon, Pretenditrin Pets.
Pretenditrin is not for everyone. Side effects may include nausea, dizziness, false sense of security, bleed-outs, and shortness of breath.
Thanks to Pretenditrin, I can do all the things I used to be able to do, but now with the added confidence that I'm doing them while medicated. Pretenditrin, because everybody deserves to be on something.
We love our drugs, right? Coming out of the faucets like tap water. But you know, there's a study every week, it seems like, that talks about just how much we love our drugs. And don't get me wrong, there's a lot of great drugs out there that are doing a lot of good. But there's a lot of drugs that are being overprescribed out there that are killing lots of people. Recent Mayo Clinic study: 3 most common types of prescription drugs: antibiotics, antidepressants, and painkiller opioids. 70% of Americans are on at least 2, are on some sort of a prescription, at least 1, and 50% are taking 2 different prescriptions. And you know, this isn't a new problem. When people ask me, gosh, this prescription drug problem, when did it happen? How did it take over? Well, guess what? It's kind of always been around. It's kind of always been around. I love this. Laudanum for your baby, too. You know, we were giving babies opiates 60, 70 years ago. And of course, the 60s, 70s, and 80s, we had a tremendous, this is the granddaddy of all drug problems. Anybody in the room remember Quaaludes? Okay, you guys are old. Keep your hands down. If you remember Quaaludes. Quaaludes, huge problem on the streets of the United States. Metrobamate, the housewife's helper. Remember Valley of the Dolls? The dolls weren't the women, the dolls were the pills. They literally called this, there were significant portions of the medical community called this the housewife's helper, that little pick-me-up, help get through the day, downers, uppers. Before folks were slinging crack on street corners in the United States in the inner city, they were selling fours and doors and Tylenol, pyrobenzamine, hydromorphone, oxycodone. But you know, the 90s, things really changed. And it was these oxycodone immediate release products that really changed the face of prescription drug abuse in the United States. This was a concentrated hit of opiate that really, this is synthetic heroin. This is really, really fantastic drugs if you're an opiate abuser. Where are we at today? Well, in 2010, we had over 38,000 unintentional drug overdose deaths in the United States. That's a death every 14 minutes. 22,000 of those were deaths attributable to prescription drugs, and over 75% of those were opiates. Prescription drug abuse is by far the fastest growing drug problem in the United States. If you look at emergency rooms, what are we seeing across the United States? Well, from 2004 to 2010, we had a 115% increase in ER visits attributable to prescription drugs. That's where no other drug was involved. If you talk to emergency room folks, talk to medical community folks who deal with this issue, they think that number is really underreported. No significant change in ER visits for cocaine, heroin, methamphetamine, the drugs we spend so much of our law enforcement and public health resources on. And you know, if you look at what's killing people over the last decade, it's not even close. The prescription opioids far outpacing cocaine and heroin. You see that increase in the benzodiazepines. We're going to talk about that a little bit, how they're abused in combination with the opiates. And it shouldn't surprise anyone, as the rate of sales in the United States has increased over the course of the last decade. The rate of death and the rate of substance abuse problems relative to prescription opiates have increased dramatically. You probably saw this slide yesterday. If you saw a couple of them, I apologize. I'm going to go through these really quickly. You know, we've got more drug-induced deaths than car accident fatalities in the United States, and it far outpaces every other kind of death. You know, homicide, suicide, injury by firearms. And again, not a day goes by where you don't see an article that talks about how prescription drugs impact some part of the community. This particular CDC Morbidity and Mortality Weekly report in July of 2013 focused on overdoses relative to women. You know, although more men die from drug overdoses than women, the percentage increase in deaths since 1999 is greater among women. More women have died each year from drug overdoses than from motor vehicle-related injuries since 2007. Deaths and emergency room visits related to opioid pain relievers continue to increase among women. You see these sorts of articles every week. And for every one intentional drug overdose death, we've got 28 emergency room admissions, 108 folks with abuse or dependency problems, and over 700 non-medical users. So suffice it to say, more Americans are abusing prescription drugs than all the other illicit drugs combined. This is the problem that's killing people in the United States. It's the problem that in every sort of measure we see. You know, this is a very easy story to tell if you're trying to convince somebody. Not that I think any of you need convincing. Most of the charts go like this. It's really a perfect storm. You have industry producing a wider variety of controlled substances, many of which do great things for a great many people, but some of which are incredibly destructive to those who want to abuse them. You have the use of Medicare and Medicaid to fund drug habits. You know, I was buying crack on street corners 25 years ago. Nobody ever gave me a Blue Cross Blue Shield card. You know, but you can fund a drug habit now with insurance. In the information and electronic era we live in, there's so much information out there. We're going to talk a little bit about Arrowhead and Blue Light, some of these sites that you really need to look at if you're in this field, just to see what's going on out there on the street. But you have social networking and blogging and Twitter, all this information about what to abuse, how to abuse it, what to use with other compounds, the synergistic effects of multiple drug use. Where are we at today? 22.5 million or so illicit drug users. Obviously, marijuana is the largest grouping, but the next biggest group are the psychotherapeutics. And what are we abusing? Well, we're abusing a little bit of everything, but we love our narcotic pain relievers. And if you look at what law enforcement is seizing, you know, we have a system in DEA called NIFLS. It's a National Forensic Lab Information System. About 80% of the crime labs around the United States, forensic labs, send us data on what cops are seizing all over the United States. So we have a really nice window for what's out there. And if you look at the last decade, the number of NIFLS cases going up for methadone, oxycodone, hydrocodone, sort of the big three opiates, you see tremendous increases, 400% for methadone, 229% for hydrocodone, and for oxycodone, and you see a significant increase for hydrocodone as well. You know, if you look at past year initiants, 2011 data that we got from the National Survey of Drug Use and Health, obviously marijuana is that biggest group. That shouldn't surprise anyone in terms of past year initiates, 12 or older. But if you add up pain relievers, you add up the stimulants, you add up the sedatives, you know, the numbers are pretty close to one another, and a lot of people would make an argument that the gateway's gone. Is there a new gateway, or is there another gateway? I think there probably is, and we're going to talk about how that impacts what's going on with heroin in the United States in a moment as well. Where are kids getting their information from? Well, unfortunately, they're not getting it from parents and educators enough. This is really an interesting problem to talk to kids about. I don't have to sell anybody that's in this room because you're here for a reason. You know about this problem. You want to be a part of the solution. But a lot of parents aren't talking to their kids about prescription drugs. So where are kids getting information? Well, they're getting it from their friends. They're getting it from the internet. And hey, you know, I don't know if you're aware of this, but not everything on the internet is true. Right? But they're going to sites like Arrowhead. How many people have been on Arrowhead? That's good. If you haven't been on Arrowhead, or if you haven't been on Blue Light, you should get on these sites and you should read about what folks are doing. It's very educational because you'll figure it out. If you get on Arrowhead and you get into a personal experiences vault, there's some really disturbing stuff in there. You know, in a basement with my 14-year-old girl, I'm in a basement with my friends. We stole 4 beers. I drank a couple beers. I took a hydrocodone and a benzo, and I didn't wake up for 9 hours. How do I make sure? I like the high, but I kind of got scared. What do I do next time? And these knuckleheads, many of whom have significant real credentials, you know, provide them information on how to get high. It's crazy stuff, but something you need to look at if you haven't been on these sites. And we're bombarded constantly with images, and we're bombarded with bad information. This is an example. West Chase Elementary School, 4th graders are getting ready to take their standards of learning tests. Teachers think, gosh, the kids are really nervous. What do we do? Let's get some prescription drug bottles. We'll put little mints in them, and we'll tell them every time they're nervous, pop a pill. Now, obviously, the teachers meant well. Really stupid. Really, really stupid. Again, we're not thinking about this problem like we're thinking about other drug problems. And direct-to-consumer advertising. We're one of only 2 nations in the world, it's actually a violation of our treaty obligations, don't tell the UN, that actually advertise our drugs. John?
At first, I was sitting in an empty room, filmed in black and white. I had a sullen look on my face, indicating I was suffering from some kind of debilitating illness.
And then an actress portraying his wife stepped up behind him and explained that the problem was only getting worse and that he needed to take action.
But how?
You should talk to your doctor about drug.
Drug?
Yes, drug. The legit-sounding medical breakthrough that just got FDA approved last week thanks to intense pressure from pharmaceutical lobbyists.
So I talked to an actor dressed as a doctor in what clearly wasn't a doctor's office, and he recommended I start taking drug immediately. Then the camera panned up and slowly faded to white.
Now we're being filmed in color, and everything is great.
That's right, we're not allowed to say that drug is going to solve all your problems by showing us running around acting like children,
Taking in the sights.
and enjoying a delicious ice cream cone.
The drug manufacturers can imply that their product has clearly changed our lives.
This is the part of the commercial where we tell you about all the side effects associated with drugs. It's important we get through this list as quickly as possible, so you don't remember any of the truly dangerous problems that we mentioned.
Problems like liver failure, suicidal thoughts,
Bowel dislocation, and heart stoppage.
as well as sudden thoughts of cannibalism. But don't you worry about that.
Because now we're surrounded by adorable kittens.
Talk to your doctor about drug today.
Drug. Vague statement of a better life. Or something.
Obviously, I'm poking fun at this, but we're bombarded with images. And abusers. I mean, you really don't hear about people with cocaine, and you're starting to hear about people with heroin problems again, but people in the news, you hear about people with prescription drug problems. You know, very rarely you're going to have a slide that has Steven Tyler, Brett Favre, and Eminem on it, right? but they all have a common problem. They all have an issue with prescription drugs. And deaths. When's the last time you heard about just a straight cocaine overdose? You don't hear about that as much anymore. You hear about deaths involving prescription drugs. And the list goes on and on. This headline, Billy Mays, America's Pitchman. You remember this guy, the OxyClean guy, 2 in the morning if you couldn't sleep, trying to sell you something? Headline, autopsy, cocaine had a role in his death. But guess what? We do the toxicology, and what comes back? Hydrocodone, oxycodone, tramadol, alprazolam, and diazepam. Probably had a contributing factor to his death as well. What are we seeing out there on the street? What are the most commonly abused sort of drugs that we're seeing nationally? And again, these trends changed a little bit, but I want to just go over them real quickly before I get into the meat of our presentation. Obviously, the big drugs are the oxycodone products, the hydrocodone products, methadone, which I'll talk about real briefly as well. We're starting to see more and more of this oxymorphone product on the street. They call it stop signs, because it kind of looks like a stop sign. The benzodiazepines used in combination, we're going to talk about that in a minute. We see a lot of alprazolam being sold illicitly on the street. And again, what the drug abuser is seeking, I'm probably not telling you anything you don't know, they're seeking these combinations, these cocktails, most common one being called the Trinity. It's the Schedule 3 hydrocodone product with a benzodiazepine and then some sort of potentiating muscle relaxer. We used to see carisoprodol a lot. We're starting to see Flexeril and some other drugs replacing those. But this is a slide that I always show because I think it's important to understand how the sale of opiates compare to other drugs. If you ask the average person on the street, what's the most prescribed medication in the United States? Most people would probably guess, well, it's probably something for cholesterol because we're all getting a little older, right? Maybe something for hypertension, maybe an antibiotic. Guess what? None of them are even close to hydrocodone. Hydrocodone is the most prescribed drug. Hydrocodone combination products are most prescribed drug in the United States. I mean, you know them under the brand names of Vicodin, Loratab, or Loracet. They're equal to morphine in producing opiate-like effects. We see them in these sort of Trinity combinations. Just to give you a little bit on hydrocodone real quick, where we're at, there's some real issues with hydrocodone nationally right now. About a decade ago, DEA got a petition from a doctor that would have liked to have seen hydrocodone upscheduled to Schedule 2. There are many people that think it's not scheduled appropriately. Based on that letter, that petition, DEA did an analysis, sent their analysis to HHS. Our analysis was that, we believe that it probably should be upscheduled as well. HHS promptly looked at that. About 7 years later, they got back with us and said they didn't think it should be upscheduled. We went back with new data. And just last year, FDA had an advisory committee meeting, 29 experts of their choosing, over 2 days, hear testimony, and they made a decision, voted 19-10 to recommend that hydrocodone be upscheduled to Schedule 2. That particular decision remains with the FDA commissioner, and we're waiting for her to rule on that. That being said, there are a number of members, both houses, that are looking to control this legislatively if HHS doesn't make that recommendation. So I wanted you just to be aware of that. If you feel passionate about what's going on with hydrocodone, now's the time to talk to your legislator. Obviously, as an administration official, the administration hasn't taken a formal position on that, so I'm not at liberty to say what my position is, but you probably wouldn't be surprised to know that I'm on one side of the fence on this. Get it? Talk to your legislators if this is important to you. And I know some of the state and local leaders around the country, law enforcement leaders, public health leaders, have been doing a great job. Tommy Farmer's been out there championing this issue as well. Let's talk about oxycodone. This guy loved it so much he wanted to put it on his arm so he didn't forget about it, right? The oxycodone immediate release product, particularly the OxyContin product, the Oxy 80s that we used to see 4 or 5 years ago, or 3 or 4 years ago, this is the drug that really changed things for it. It was a game changer on the street. That immediate release, that bolus dose of opiate. This is what traffickers wanted. This is what the abuser population wanted. Sold generally in cocktails. If you substitute the oxycodone for the hydrocodone, it's now the Holy Trinity. You gotta love these kind of names, right? I mean, this is great. Now, there has been a new formulation of that OxyContin product by the manufacturer, and it's actually helped. You can still abuse this product. It's just much more difficult to grind it up, to snort it, 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 snort and methadone. But why were people overdosing? Patients weren't taking the drug as directed. Physicians weren't properly prescribing this drug. The pharmacokinetics of this drug are very, very different than other opiates that are being prescribed for pain. Non-medical users ingesting it with other substances, the synergistic effects of methadone can be really dramatic. And again, you know, it was used in narcotic treatment facilities for people who were not opiate naive. So you get the opiate naive abusing methadone, real problems. And again, deaths everywhere. Real quickly, the Opana or the oxymorphone products, we're seeing a lot more of these on the street. I just wanted to highlight this for you. We're seeing a disturbing trend in some states that are having some successes targeting OxyContin or oxycodone products and hydrocodone products. We're starting to see more and more of this oxymorphone and hydromorphone products on the street. The benzodiazepines, again, I just wanted to mention them because they're used in combinations. Alprazolam seems to be the drug, and again, you know, the street culture of the drug abuser. There are other benzos that are just as good, but for whatever reason, they think alprazolam is just so great. They call them Z-bars on the street. We see a lot of that nationally. I wanted to talk about the amphetamine salts, the ADHD drugs, real quickly. Has anybody noticed that a lot of kids are going off to college now and figuring out they have ADHD? You know, on college campuses, this is a huge, huge issue. College crack or college crank. The problem is a lot of these kids that are abusing these drugs are segueing into opiates and segueing into benzodiazepines. Some recent numbers, 2012 partnership study that just came out in April of this year, some really disturbing stuff when you look at ADHD drugs. 9% of teens reporting misusing or having abused them in the last year. 1 in 4 teens believes that they can be used as a study aid. And here's the frightening part. Parents aren't doing a very good job of dispelling that rumor as well, with significant amounts of parents thinking this is not a bad thing. So how are the kids getting these prescriptions? Well, you remember they go to places like Arrowwood and Blue Light. Arrowwood and Blue Light say, go to the internet, pull up the Diagnostic and Statistical Manual of Mental Disorders, pull up ADHD, read a little bit about it. Hey, guess what? There's 10 or 12 symptoms. And because there are no laboratory tests, neurological assessments, or attentional assessments that have been established as a diagnostic for ADHD, you do that, you name about a half a dozen of those symptoms to the average family practitioner. Guess what? A lot of these kids are getting scripts, making a lot of money on college campuses. Kids are getting themselves in trouble with it, particularly the synergistic effects of these ADHD drugs in combination with alcohol, marijuana, and other drugs. Okay, so real briefly, kind of talk to you about the scope of the problem, how we see it, its size, a little bit about what we're seeing abused. This is really sort of the meat of our presentation. I wanted to talk to you a little bit about the Controlled Substances Act. And again, I think it's important that you understand the Controlled Substances Act so you understand how traffickers are getting around it. Because we have a phenomenon with the prescription drug abuse problem where the trafficking schemes have morphed with the controls that we've been able to either enforce more diligently or additional controls that we've been able to put on through the CSA. But the cornerstone of the CSA is this closed system of distribution. If you're a person that handles controlled substances in the United States, you have to be registered with DEA. And you've got to report into a system the movement of drugs. Congress wasn't stupid when they designed this. Congress recognized that controlled substances were very different than legend drugs. They had a much more high propensity for abuse, and they were killing people and destruction. So what did Congress do? They designed this system. So the 1.5 million DEA registrants have to participate, from importers to manufacturers, distributors, practitioners, hospitals, pharmacies. And everywhere through this system, we've designed processes to try to minimize diversion. So we establish drug schedules. You have to be registered. We establish quotas for how much drug can be out there. We have to report into this ARCOS system. This is the system we use to track the movement of drugs. There's security requirements, record-keeping requirements. We do cyclical investigations. So as best we can, we have a closed system. Oddly enough, this is the envy of most of the world. Most of the world, when you go around and talk to drug control people, they say, gosh, we wish we had a closed system like yours. Unfortunately, we have a closed system with some leaks. So, and that's what we're going to talk about. Because everywhere in this system, from raw material manufacturer, importer manufacturer, dosage form manufacturers, distributors, pharmacies, all the way down to the patient, off to the side there you see different U.S. code and or regulatory requirements on people within that system. Everybody's got a responsibility if you're going to handle controlled substances. Let me talk about just a couple of them, because they'll help us understand how things are happening today. If you're a distributor of controlled substances, you have to design and operate a system of suspicious orders. What's that mean? Well, suspicious orders include orders of unusual size, deviating substantially from a normal pattern, and orders of unusual frequency. Sounds pretty straightforward. You have to know your business model. You have to know what's going out your doors. If something looks suspicious, you got to have a system that catches it. You got to report it to the DEA. That's a requirement to be registered as a distributor. Second important sort of responsibility for different groups within this system are our practitioners, our doctors, nurse practitioners if they have prescribing authority in particular states, physician's assistants. A prescription for a controlled substance to be effective has to be issued for a legitimate medical purpose by an individual practitioner acting in the usual course of professional practice. What's that mean? It's codified in U.S. v. Moore. Let me tell you about Moore real quick and help you understand the issue a little bit. Moore is a doctor in the District of Columbia. He runs a drug treatment facility, and he just hands dope out like you wouldn't believe. This guy is a prolific drug trafficker. There are no medical exams. He's just moving out as much stuff as he can move out, okay? DEA, local authorities, build a case on him, arrest Moore, take Moore to trial, Moore's convicted. 21 U.S.C. 841, drug distribution. Moore appeals to the Court of Appeals, and his lawyer, smart argument, says, hey, wait a minute. This guy's a DEA registrant. DEA licenses him, essentially, and allows him to prescribe controlled substances. You're prosecuting him, government, for the very activity you say he can do. People on the Court of Appeals listen to that and say, well, you know what? You got maybe a valid argument. It goes up to the Supreme Court. Here's what the Supreme Court says. Supreme Court says, you know what? Court of Appeals, you're actually right. DEA does allow him to do this. But here's the issue. If he does it for a legitimate medical purpose, in the course of a normal professional practice, DEA can't do anything to him. But Dr. Moore, it wasn't normal. He didn't have a normal relationship. He was just pushing dope out the door. So guess what? He's not a doctor anymore. He's a dope dealer. That's the standard. It's important to understand that standard when we start talking about pill mills and rogue pain clinics. And the last of these sort of responsibilities is what our pharmacists do, sort of our last line of defense. Pharmacists have a corresponding responsibility to ensure that a prescription is valid. So this argument that, hey, listen, I'm a doctor, I prescribe, you just fill, that doesn't work. If you're a pharmacist, you have a corresponding responsibility. And guess what? Pharmacists are our last line of defense. And pharmacists do a great job. And let me just say something real quickly. If you're a practitioner or a pharmacist sitting out there in the audience, 99% of the people in this system do what they're supposed to do. It's the 1% that cause us all the issues. But everybody has a responsibility in the system. And there are those who are pushing back. Right now, the American Medical Association, which represents about 12, 13, 14% of the doctors in the United States, has a resolution that they're trying to push up through their resolutions committee that essentially wants to tell their membership, now think about this, time of a national prescription drug crisis. It's an epidemic. The CDC used that, not DEA, right? CDC, National Drug Epidemic. People are dying. The AMA wants to tell its constituency, don't talk to pharmacists. Don't have that interaction because it's none of their business. You prescribe, they fill. Well, there's a little problem with that. It's a violation of law. We'll deal with that. But just to let you know, there are stakeholders in this system that are pushing back. Now, there are a lot of docs out there who think that's absolutely ridiculous. And that's probably why the AMA is a lobbying group and represents 12% of the doctors. So we have this system of checks and balances. Last line of defense being the pharmacist. What happens when these checks and balances collapse? Well, let me give you some ideas. We have large-scale diversion. Let me give you an example of that. In 2009, the average purchase for all oxycodone products from pharmacies in the U.S. was $63,000. In 2010, it was $69,000. That's average. In 2009, the top 100 pharmacies in Florida, $1.226 million. 2010, $1.261 million. Okay, you're a drug distributor. Suspicious orders, $69,000 to $1.2 million. We call that a clue in law enforcement, right? Somebody should have caught that. Do you think people were exercising their responsibilities under the Act like they should have? No, they weren't. They weren't. So if you don't live up to your responsibilities, these are the problems we have. So you understand the Act a little bit now. Now you're all experts on the Controlled Substances Act. So let's talk a little bit about where people are getting their drugs. What's the most frequent method for obtaining a pharmaceutical controlled substance for non-medical use? Any guesses? From your friends and family for free. It's sitting in your medicine cabinet. We are making this really, really easy. Why are there so many drugs in the household? A lot of people would argue that unreasonable quantities are being prescribed. Who's went to the dentist lately and had something done and gotten 40 hydrocodone tablets? If you need 40 hydrocodone tablets for a bad tooth, your doctor screwed up, right? There's too much out there. Doctor shopping, another major method for folks getting drugs. When we look at the doctor shopping phenomenon in the United States, there's really two sorts of things we see. We see these individual patient drug seekers, and then we see these large trafficking organizations that are involved in doctor shopping, but they're all looking for the same thing. On the physician front, they go to multiple physicians, and they're looking for physicians who are willing to prescribe controlled substances with little or no oversight. They target pharmacies. They use multiple pharmacies to try to mask their activities, but they also go to pharmacies that are known for dispensing. We're going to talk about our pharmacy drug awareness conferences we're doing right now. And it's amazing, the honest pharmacist will tell you, I filled that one script and I wasn't sure, but then I got a van with 12 people from Florida the next day. These folks have a network. They target pharmacies, they target doctors who they feel aren't doing the appropriate due diligence. Just an example of some drug records we took from a pharmacist. I like this guy. He's like the anal retentive drug trafficker. He's got all of his notes down here for the places he hits, what he talks about in terms of what his ailments are when he sees a particular physician. It's very commonplace that we see in these doctor shopping groups. Of course, he's got an agenda for where he's going over a particular month, and that's what he picks up in 30 days. This is one person, part of an organization of 30 or 40 drug seekers. He obviously gets the amount of pills back from the organization to maintain his high, but the rest of it goes out on the street. Big, big, big money. You look at that oxycodone column, if those are all Oxy 80s, that's a lot of money at $80 to $100 a pill. Okay, so you get it through the medicine cabinet. You get it through doctor shopping. Let me talk a little bit about the internet. It's not as big a problem as it once was, but it's important for you to understand the internet to understand where we are today. 4 or 5 years ago, the prescription drug abuse problem was largely a hydrocodone problem, and it was hydrocodone being sold over the internet. Tremendous quantities. How did it work? Well, I'm sitting in Montana, and I find a website in Florida. I want hydrocodone over the internet. It goes through a server in San Antonio, bounces through the web company in Florida, goes to a doctor in New Jersey who's getting paid $1 million a year to sit at his kitchen table in his boxer shorts and write 2,000 prescriptions a day. It goes back through the web company to a filling pharmacy in Iowa, back up to me in Montana. That's how it works, and that's what the pharmacy looks like. Does anybody's pharmacy look like that right now? If it does, we want to talk to you afterwards, right? How bad a problem was this? 2006, 1 year, 34 pharmacies in the state of Florida. Top one moved almost 16 million hydrocodone tablets. You took the top 34, it's almost 100 million hydrocodone. This was a huge, huge issue. One case in Minnesota, just to give you an example, how much money these folks were making. You know, this is the guy's attitude toward his customers. Didn't think much about him. Little note he had up in his little tech center. But he really cared about his business. He had all these little whiteboards with instructions for all his folks there that were monitoring these internet orders. I love this 300 cash bonus for the highest Discover card order. This is big business, right? And why is this guy doing this? Because he made a ton of money. And in about 18 months, he collects all this stuff. And when we hit him, we seize $4.3 million. Not a doctor, just an entrepreneur. $4.3 million that we seized from him in that short period of time. There were 300 or 400 of these operations rolling at that sort of level on the internet, and many that were smaller as well during that time frame. So what stopped it? Ryan-Haight Online Pharmacy Act. Remember our controlled system? Congress did a great favor for us, passed the Ryan-Haight Online Pharmacy Act. What's it say? It shall be unlawful to knowingly or intentionally deliver, distribute, or dispense a controlled substance by means of the internet, or aid and abet in the violation. And the important thing is you had to have that in-person medical evaluation by a prescribing practitioner. Kind of kills the internet delivery system when you actually have to see somebody, right? Right? You could, though, DEA said, the law says, you could go to DEA and get a modified registration if you really want to do this. But this really wasn't about legitimate medicine. Because you look at our current controlled substance registrant population, we have about 1.5 million folks that are registrants. Of that group, almost 69,000 pharmacy registrations, so any one of those can come in for modified registration. So how many internet pharmacy applications have met the requirements for approval? Any guesses? None. Zero. You know why? Because this wasn't a legitimate method of moving controlled substances at that time. This was all about drug trafficking, drug distribution. We have about 13 that are pending, but most of them have just been withdrawn for other reasons. So what took the place of internet-controlled substance distribution? Again, traffickers are smart. They're not going to leave all that money on the table, right? They're going to figure out another way to do it. Where did it all go? It went to rogue pain clinics and pill mills. This is where we're at today, and we're going to talk about the evolution of this right now. This is a huge, huge issue. I was an assistant special agent in charge of the Washington field office when up till my current job several years ago. This is actually a photo about 6 o'clock in the morning outside of a pain clinic in Northern Virginia. This is in a strip mall. It's one of these little nondescript strip malls that have title companies and sort of nondescript, not really the sorts of places where you had a lot of frequent customers coming. No doctor's offices, that's for sure. We're told by our state and local counterparts, hey, we got a real issue. We got this new doctor's office. People are lining up early in the morning. They're doing drug deals in the parking lot. Fights, all sorts of nonsense. Cops roll through there. I love this story. This guy right here, he's the bouncer. Okay, now, again, clue, Tommy, it's a law enforcement clue. If you go to a doctor's office and you have a bouncer, that's probably indicative of a business model that's a little different than we normally see, right? And he proudly tells the cops, hey, I'm not one of these guys, I'm the bouncer. I'm here to keep order, right? So, let's think about that relationship again. Remember, when we talk about pill mills, controlled substance for a prescription to be effective, legitimate medical purpose by a practitioner acting in the course of a usual professional practice. Let me show you how unusual these pill mills and rogue pain clinics are. But to understand this problem, you have to understand Florida. Let me tell you real quickly what happened in Florida, tell you where we're at today, because it really gives you a flavor for what happened. The vast majority of patients that were visiting these Florida pain clinics, and Florida was literally ground zero. It was the Columbia of the prescription drug problem. 99 of the top 100 oxy prescribers in the United States over the course of 2 or 3 years at the peak of this were in Florida. So they were really supplying the bulk of the eastern United States. And these patients were coming from here. They were coming from Georgia and Kentucky, Tennessee, Ohio, Massachusetts, all up and down the eastern seaboard. Really a tremendous problem. Think about how ridiculous this system of delivery is. I'm in Massachusetts and I want drugs. I'm a legitimate pain clinic. Do I go to Massachusetts General, great hospital? Nope. Do I drive down through Rhode Island? Do I go through Connecticut? All these great hospitals. I've even got to drive through New Jersey. Is there anybody from New Jersey here? There's good hospitals there too, I promise. You got to drive down through all these great hospitals all the way down the eastern seaboard to go to the Mayo Clinic of Jacksonville, right? No. To go to the Pain Center of Broward County, short waits or will pay you, earn money for patient referrals. Remember, normal practice. I can't even get an appointment to see my doctor, but they're going to pay me if I have to wait long, you know? No waits for walk-ins, $50 initial visits. Look how happy these people are. They don't look like they're in chronic pain, right? They're so happy we're going to use them for our outpatient detox ad as well, right? These places were just set up to push pills. The ones that tried to go quasi-legitimate started asking for things like, hey, you know what, we need an MRI. You know what we'll do? Let's set up an MRI in a trailer behind the strip club a block down. It doesn't work. I bought it from a guy at a wrecking yard, but we've got 2,000 images of the same bad back that we'll just hand out to everybody that comes for $250. They were making money off MRIs. Where were they getting their doctors? Craigslist, right? That's where most doctors, get hired out, right? Again, not the normal delivery system. Let me walk you through what a pain clinic looks like. First thing that happens is you're going to have to get in line. That's kind of synonymous with all. You're going to get in a long, long line, okay? Unless you're like this guy who says, hey, listen, cops look for these lines, so let me show you what he did. John, can you play this? You want to look off to this side. He's essentially told all his customers, this guy's in jail now, he essentially tells all his customers, nobody come in until the manager, nobody line up until the manager comes in. We don't want the cops driving by and seeing this. So here he is. Here's the manager. This is actual surveillance video. And here come the customers. Now, policemen in gallows humor, when this came into the office, one of my people said, hey, boss, have you seen the zombie video? It's really not funny, but yeah. What I love about this video, too, though, is it kind of captures the whole thing. Here's the owner. He's going to pull in a minute in his $50,000 car, which we own now, by the way. Okay, so you're going to have some lines. When you get in, you're going to have to follow some instructions. Now, again, another clue. If you got a bouncer, you can't get in line until a certain time. Of course, you would never get in line to get to your doctor's office anyway. And they say, hey, no weapons. Does your doctor's office ask you to, check your weapons when you come in? Problem, right? How about no cell phones? Why do you think they're doing things like that? Cops and body wires, cell phones. Again, lots of instructions. Got to have exact change, cash only. Again, another clue, right? Most doctors' offices take insurance, take a check, take a credit card. Got to follow all these instructions. There's always going to be a lot of them. No insurance for any roxycodone. Kind of a clue, right? Okay, you're in now. You follow the instructions. They're still going to pat you down. Some of these places at the height of this, and it's happening around the country now as well, they're patting you down for body wires and they're patting you down for weapons. So you got to check all your guns in, right? I love this. We have designer handguns now. Kind of frightening. You got all the weapons, your shivs, your knives, all the stuff. I'm sure this looks like your guys' doctor's office, right? Okay, once you get in, you got to take a seat in the waiting room. That's if you're going to find one, because it's going to be a while. It's going to be a long while, surveillance video of one of these places. You might spend 4 or 5 hours in there, right? Finally, you get your scripts, and they're moving so many scripts, we just stamp them now, right? Got the Trinity stamp, Xanax, Roxycodone, right? All they need is that carisoprodol. But you're not going to get your script until you pay. Does your cash drawer at your doctor's office look anything like this? These are real photos from pain clinics. Crazy, isn't it? I mean, for those of us that have worked drug law enforcement, we know that one of the toughest things for a meth trafficking organization or a coke or heroin trafficking group is keeping up with the money. What do? Just rubber band it and stick it in the drawer. This looks like a dope dealing operation to me. Of course, you got to pack them up properly to ship them out of state because you're coming down to these pain clinic environments and you're not just going to one pain clinic, you're going to a couple of them and you're getting a lot of pills. And you're selling a lot of them to feed your addiction, right? So you got to bring your false bottom canister to pack all your pills up, to get back on the bus, the OxyContin Express, to get back up here to Appalachia or someplace, right? But you might use a little in the parking lot. John, if you wouldn't mind.
Do you think that the doctor that prescribes you the pills knows that you're addicted?
Yes, for sure.
And why does he still prescribe your pills?
Because he wants money. That's it.
How bad was this in Florida? Okay. 2007, you have 4 pain clinics in Broward County. By the end of 2008, at the 10-15s, when Ryan Haight kicks in, you've got 66. At the peak in 2010, you have 142 in one county. You had 1,500 pain clinics in Florida at the height of this thing. Really out of control. Why is it happening? Again, it's all about money. They don't want to be outdone by the internet guys, right? You make a lot of money doing this. One of the early cases, we had a forensic accountant come in and tell us, hey, I think this guy moved $40 million through his books in 6 months or a year. And we said, that doesn't sound right to us. Till we seized $41.5 million off a doctor-wife practitioner team running pain clinics in the Houston area. Tons of money. They're paying doctors $1 million a year. And this is our boy from the, it's his car, right? We got it now. These are all the cars he collected from that little pain clinic he was operating as well. Not to be outdone by our friends. So what happens? Florida steps up. Florida passes some tough controls, the most important being in July of 2012, clinics have to turn over their C1s, C2s, and C3s, and they can't dispense from clinic environments. That Florida activity, coupled with some really organized enforcement efforts, and I'll talk about that when I talk about what we're doing on this from DEA and state and local law enforcement, really turned the nozzle off on Florida. But what do you think the clinic response to enforcement actions in Florida legislation was? In Florida, what do you think their response was? Buy pharmacies, right? We can't dispense anymore, so let's buy our own pharmacies, or we'll just move to another state. How bad was it? 2010, new applicants in the U.S. for independent pharmacies down 8.3%. In Florida, they're up 55%. Change the business model. Again, laws change, they adapt. Too much money involved. Organized crime. Who was applying for these places? Organized crime guy, the Boston market worker. Father owns a pain clinic, mom works at a pain clinic, father's doctor at a pain clinic, the bartender, exotic dancer for a vast knowledge of pharmacy, the truck driver, the drywall business guy, the secretary at the pain clinic, and the lawn care business guy. Really out of control. Straw ownership purchases, same people that were involved in these rogue pain clinics, just trying to open up pharmacies. DEA took the unusual step. We don't do this anywhere else in the country. We started interviewing every single new pharmacy applicant in Florida, and most of the time they withdrew immediately because it was the same story. Why do you want to own a pharmacy? My friend Jim said he'd pay me 20 grand if I came down here and did it. I mean, it's straw ownership. So if they're not buying pharmacies, what else are they doing? And this is the part that impacts all of you. They're moving. They're moving to other states, places like Texas and California, and they're moving up to Georgia, to Tennessee, Kentucky, Ohio, Missouri. They're everywhere now. Let me give you an example of how quickly they've spread. If you look at Georgia, 2009, 2010, they had 15 to 20 legitimate pain clinics. These were owned by physicians, they accepted other insurances, they followed pain management guidelines. Patients needed appointments. Wow, that's an oddity, right? The kind of business model I've been showing you, these folks actually needed appointments. They used alternative therapy methods and they prescribed things that weren't controlled drugs. These were normal pain clinics. Okay, that's 2009, 2010. Let's flash forward to 2012. Now we have 125 or so. You superimpose them over maps, guess what? They're all along highways. Why do you think they're along highways? To service the population that used to drive down to Florida, right? Out of control. Who owned these things? When we kind of do a look at snapshot of who owned these things, folks from other states, convicted felons, organized crime figures, people that had ties to that Florida industry. I'm telling you right now, if you don't have a pain pill mill problem or rogue pain clinic problem in your area, you're going to have one soon. There's way too much money involved. I know Tommy and I have talked about this. Tennessee's got a big-time pain clinic problem right now. Big-time pain clinic problem. So what's DEA doing? I think Regina LaBelle probably talked about those 4 areas, the national strategy to target prescription drug abuse. We're heavily, and we support our state and local counterparts on prescription drug monitoring programs wherever we can, but it's not really our role. Those are state systems, and they work. By the way, I will tell you this, states that have strong prescription drug monitoring programs and practitioners and pharmacists that use them and law enforcement that might have some access to them, it makes a difference. It really does. The distressing thing is we only have three or four states in the United States that require usage, right? And in other states, the usage numbers are just really abysmal. But we're looking at disposal in a big way and working on that. I'm going to talk about take back and our proposed regs. From an enforcement perspective, I'll touch on that real quick, and then I want to touch on what we're doing on an educational front. And again, everything we're doing in all 3 of these areas is just to try to make sure that people don't go outside that legitimate methodology or that legitimate process for obtaining a controlled substance. We've got to cut off the source of supply. How are we doing that? We're, on the disposal front, we're heavily involved in these national take-back initiatives with our state and local partners. State and local partners do all the work. We just supply some of the funding and some of the resources and the organization of doing it on a one-day type thing with a national sort of platform. But these things have been remarkably successful. Every time we do one of these, we've done 6 of them. We've collected 2.8 million pounds of drugs. Again, not all of these are controlled because we don't care. We're not asking questions. We just want this stuff out of medicine cabinets. But every time we think the numbers are going to go down, we're shocked. The last one, we collected way more than we'd collected in any other ones. The next one's going to be October 26th. But these are really great, and I mean, if you look at what they look like, the April 27th, 2013 event, 4,300 law enforcement agencies participated around the country, 5,800 sites, again, collected about 742,000 pounds. Cops box it, seal it, count it, weigh it, consolidate it, secure it, and it's incinerated safely by us. It's a great program, really works. People need to continue to participate in these things. The other tool we have is the Secure and Responsible Drug Control Act. DEA has the authority now to promulgate regulations to help the ultimate user, to give them additional options to dispose of drugs, and we're well on our way to doing that. In December, on December 21st of 2012, we actually published a notice of proposed rulemaking. So the rules that are going to implement that law, very difficult process for us. It's not lost on us that it took almost a year and a half plus to write these. It's because there were so many stakeholders involved in Washington. You guys might be surprised to hear this, but it's tough to get things done in Washington these days, right? But we're excited about one thing. The notice of proposed rulemaking's out. There's a 60-day comment period. We received an unprecedented number of comments on this, literally hundreds of comments. We have to answer all of them. We have a team assigned to this. We are committed to trying to get this disposal rule out, to give ultimate users other options by the end of the year. Now, the next question everybody asks is, well, what are the other options going to be? Because that's what I would ask. In the process that we're in right now, we are prohibited by the Administrative Procedures Act to talk about what that final rule is going to have in it, because we really don't exactly know yet until all of the comments are assessed. Having said that, if one were to read the notice of proposed rulemaking, published on December 21st, out there for everybody to see, there were 3 broad areas that were sort of outlined. Enhance or continuing with law enforcement take-back events, and allowing law enforcement to do what they need to do in secure settings to collect drugs. There is a mail-back program that was discussed in the NPRM. And there was also a process by which pharmacies could voluntarily, if they met certain security requirements, have collection receptacles. I can't say all of those will be in the final rule, but that's the broad contours of it. But suffice it to say, it will give the ultimate user other options. What are we doing on an enforcement front? Well, our administrator back in 2008 sort of set up this two-pronged program. We beefed up the first prong of this was our tactical diversion squad teams. These are these hybrid task force teams. We had 5 of them prior to 2008. We have about 58 operational right now. We'll have 66 operational very soon. But these are the sharp edge of the spear, for lack of a better term. These are task force groups led by a gun-carrying special agent, 2 or 3 special agents, 2 or 3 of our talented diversion investigators, and then the most important aspect, state and local police officers. And they use all the tools that a task force group would use to go after a drug trafficking organization. Undercover buys, surveillance, wiretaps. You know, if TDS gets you in your sight, it's probably not going to be a regulatory thing. Somebody's probably going to jail. This is the worst of the worst, because this is where this problem is right now. The second prong of this, and equally important, is it freed up our small, talented diversion investigator cadre in DEA to focus on what they do best, which is looking at diversion in the supply chain. So we've stepped up regulatory investigations, and it's really paid some dividends. I'll show you that in a second. But again, 66 of these are approved, 58 are operational on the TDS front. Kind of see a graphic of where our tactical diversion squads are nationally. Really successful program. These groups see so much money, it's unbelievable. I mean, it's really, they're really phenomenal groups. They're doing great things. And again, the other thing that we're doing, the reason we design these things is to really crack down on the major criminal trafficking schemes that we see at any particular time. And right now, that's pill mills and pain clinics. That's what these teams are going after. On the Florida front, just to give you an example, right prior to those laws passing in Florida, we actually detailed 11 tactical diversion teams down to Florida to work with our TDS based in Miami to target pill mills. So we had 12 of these teams running around the Tri-County area in South Florida there, targeting these doctors. And it was very successful. You know, we were able to target 80 different physicians. We locked a lot of people up, closed a lot of pain clinics. Very successful operation. On the regulatory oversight side of this, we have really stepped up the number of cyclical audits we're doing on key elements in that supply chain. And again, we're investigating and inspecting all of these new pharmacy applications in Florida. Again, that's sort of our diversion presence around the country. The other thing that we've stepped up is something we started in 2005. We called our distributor initiative. We actually pull the nation's largest drug distributors in. We show them their own ARCOS data that they send in to us and say, hey, remember that suspicious order monitoring thing? This is your data. You know, you guys need to be looking at this stuff. It's to help them through this process, but if they don't take action, we use all the administrative, civil, and criminal tools we have to take action. And it shouldn't be lost on anybody that in the last 18 months, we have targeted levels of supply chain that heretofore we haven't. Largest fine in controlled substance history several months ago against Walgreens, $80 million. We are committed at DEA to targeting diversion wherever it's at. We take a lot of flack in Washington from stakeholder groups. You know, you're targeting independent pharmacies, you're targeting chain pharmacies, you're targeting small independent distributors, you're targeting the big distributors. Here's a news flash. This is what I tell everybody. I'm consistent on this. We don't sit around in a room and say, let's target this group. We sit around in a room and try to figure out how we get assets out to our people in the field, and they target diversion wherever it's at. We don't tell them where to go. Just so happens there's diversion at high levels of supply chain. We're committed to that, and we're going to use every tool we have in our toolbox to try to stem the tide of this problem. We're not going away. We keep telling, we meet with industry. Most of them are great partners. Some of them aren't. Some of them are good partners but still like to complain. We're not going away. This is a tremendous national epidemic, and we're going to be all over this problem. The other thing we're doing, I'll finish with this, is education. We have these pharmacy drug awareness conferences. We're going to have one in Tennessee next year, I believe. We've trained over 5,000 pharmacists on corresponding responsibility. We see pharmacists as critically important. They're the last line of defense on this. They're They're the ones that hand the drug to the ultimate user. We want to make sure that they understand what their responsibilities are under the Act, but also what their authorities are, what they can and can't do. You know, this whole thing, well, my chain says I have to do X. Guess what? Your chain's not on the hook for the liability. You are for making sure that's a valid prescription. Now, if the chain's involved in some sort of conspiracy, then that's a whole other thing. But suffice it to say, we want to educate this critically important portion of our registrant population. We're also worried about them. We're seeing record numbers of pharmacy robberies, armed robberies, and burglaries around the country right now. We've put together a pamphlet with the National Association of Boards of Pharmacy. If you want copies of this, you can certainly get a hold of John or I, and we'll get you copies of this for whomever would like to see it, because this is a huge problem. We got a lot of stuff on our website. If you haven't been to our website, we've got a lot of stuff that might help folks. We also have a couple sites that talk to kids. JustThinkTwice.com addresses, kids, if kids want to learn a little bit about it, about the drug abuse problem. And then Get Smart About Drugs for educators and parents. But the thing that we're trying to stop right now is just this tide of crime, violence, and death that's associated with this problem. Things like this just should never happen. Guy walks into a pharmacy in Long Island looking for hydrocodone, kills the pharmacist, kills a pharmacy tech, kills 2 customers, picked up by his drug-addled wife, and seems off. And it's not just in places like New York. It's all around the country. If you look at the pharmacy armed robbery rankings by state, these are numbers that we get through our drug loss reporting. The numbers are going up. The numbers, I think, were like 650 last year, John, in 2011 rather. In 12, we had 782. The number seems to be growing. You can see, for example, I'll show you an example. Tennessee had 42. If you break that down, they have 42 of the 782 nationally reported to us. This kind of broke it down by county. If you look at 2013, the numbers are pretty robust. There's some lag in reporting too, so we think we're going to have, unfortunately, a large number in 2013 as well. Again, that just sort of breaks it down by county there. And it's happening here. This was just in Knoxville. I just saw this a couple days ago, so pardon me just to pull this out, but in May, we have, in Granger County, we have some guy go in to steal oxycodone, kill 2 people in a pharmacy. The guy's a former cop, too. I mean, crazy, crazy stuff. Got to stop this violence. When I have sheriffs tell me, and I had a sheriff tell me this, pharmacies are my new crack houses. And that's distressing. And we really, this is a problem I was mentioning to Bill earlier. This is a problem that we really need all hands on deck for. This is like no other drug law enforcement problem we've dealt with. We need treatment providers. The treatment folks are fantastic sort of resources for law enforcement to figure out what's out there. If you're not talking to them, you should be. We need the medical community, the practitioner community. There's some great, I know I was a little hard on some of the practitioners earlier. There's some great practitioner groups out there right now that are really championing doing the right thing as well. So that's kind of what I had. I know I went through that really quickly. I was only 5 minutes over. Am I in trouble, Bill? Okay. So I could take some questions, but I don't know what your timeline is, so I'll leave it to you. Thank you.
What did Florida do to cut back their pancakes just because of enforcement of the state of Florida and stuff?
Now, the state of Florida actually passed 2 pieces of legislation, and the most important kind of component was on this second piece that essentially said you can't distribute from a pain clinic, because their whole business model was based on coming in the door, a no exam. They had doctors in there, but they really weren't doing an exam, and then selling you the script. I mean, they were charging, just to let you know how the pain model works, it's $250 for an initial visit or thereabouts, maybe $650, $700 to $1,000 for a Trinity prescription, which might have 90 to 120 opiates. And they're making a lot of, then maybe they send you for an MRI at $250. I mean, they're making money off every piece of that sort of drug delivery process. So, yeah, no, their law worked actually. Their can't dispense from a pain clinic or a doctor's practitioner's office really worked.
With all the federal restrictions on undercover activities and stuff, certain of these type of either pain management or substance abuse counseling programs, how do we on a state level get in and investigate this epidemic in our county?
The only real restriction at a federal level is for, and John, correct me if I'm wrong, it's for treatment, narcotic treatment facilities. I think we need to get some sort of approvals before we do some things. But the average pain clinic, no.
But that's what they call themselves, the treatment programs, and the view from morphine is just going right straight out and being sold.
You know, we should talk afterwards, because you can talk with some of your, there's some stuff we can do. There's some stuff we can do federally. These are, you know, this is another part of this problem. You know, we've got to educate drug law enforcement folks who have been doing things a certain way. You know, there's a certain way you build a coke, heroin, or methamphetamine case. The undercover activity in a interaction with a registrant or a practitioner is very different. There's certain things you do not want to do, and there's certain things you're looking to do. So, you know, we're trying in so much as we can to put on training sessions, and we're working with the U.S. Attorney's offices to educate cops and prosecutors on how to prosecute these cases as well. So, sure.
Can you comment briefly, your comment about the AMA putting out the statement that we shouldn't speak with pharmacists? I'm a practitioner, and
Sure.
Pharmacists have been very, very valuable. Pain management here in town. Can you give us, people here, a little background on that?
Well, you know, we read about it in newspapers like everybody else. We were actually really shocked about it, you know, because there's some practitioner groups out there that are really great, that are champions on this issue. So we think it was some tone deafness on the part of AMA in Washington to even think about this, because, you know, realistically, how can interaction, you know, not be a positive thing? And I'm glad to hear you say that, because most of the practitioners we speak to say, we think that's ridiculous.
Well, however,
Sure.
what I do know secondhand, I'm not a member of the AMA because I don't believe they represent my interests. But again, as a practitioner, Walgreens in particular were asking for information that our malpractice attorneys were telling us we cannot give because of HIPAA. So it's not that we don't want to cooperate with the pharmacists, but we've got someone saying that we're at risk if we give it, and we have the pharmacists asking for things that we don't think they need. I don't know how to resolve that. But
Sure.
we've been telling our patients the same thing, go to another pharmacy.
That might be a subject for the upcoming breakout session.
Sure. Yeah, you know what? That's an interesting point. I really don't have an answer on you know, I hear the hide behind HIPAA thing a lot, and I'm not so sure that the type of interaction that we're talking about, the types of decisions that a pharmacist is trying to make to ensure that they've exercised this corresponding responsibility requirement that they have under the law, really gets to the point where you've got HIPAA-related concerns. But again, you're hearing it, so. But yeah, I'd love to talk to you about that afterwards. That's interesting.
Very briefly, I'm on the HHS, and there's not going to be any HIPAA problems between communication from provider to provider, pharmacist to physician, and those types of communications are not going to violate HIPAA.
Okay, Alan, we're going to have to break.
Sure.
We got a break.
Thank you.